Dear colleagues, in partnership with the Société Francophone de Nephrologie, Dialyse et Transplantation, the Österreichische Gesellschaft für Nephrologie and the Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Dr. Heine Kaminski in Bordeaux, with whom we would like to discuss CMV infections in renal transplant recipients for the second stage of our Tour Académique 2023. So we are still in Bordeaux. The cyclist caught up with us, arriving earlier today from Mont-de-Marsan. Dear Hannah, it's a pleasure to host you. Thanks for being with us tonight.
Also, thank you for the invitation.
So Hannah is a nephrologist and has a particular interest in infectious diseases, and she's published a large amount of articles on CMV infections in solid organ transplant recipients, and she's leading the ongoing Project Horus on CMV infections in Europe. It's a large consortium. So Hannah, it's a great pleasure for us to have you and to discuss this topic with you thereafter. Thanks a lot.
Thank you. Yes, so the goal of this presentation is just to give an overview about CMV infection in kidney transplant recipient, and also the most recent thing that we hope will help to improve the management of this opportunistic infection in our patients. So just some few words in introduction about this disease. So CMV disease is an old but persisting problem in transplantation. So we called it the troll of transplantation because even if we already known it a little bit, it's still one of the first opportunistic infection in the field, and we are still trying to improve its outcome. So problem of this herpes virus in the context of transplantation is on one side the direct effect of the virus on tissue, and because of its large tropism, it could lead to several diseases such as retinitis, encephalitis, hepatitis, and the most frequent disease in kidney transplant recipient is the colitis and the pneumonia. But on the other end, the other problem we have with this infection is its direct effect, because it has been associated in several studies to an increased risk of acute rejection, other opportunistic infection, PTLD, cardiovascular event, and so it has been associated with an increased risk of both morbidity and mortality in our patient. So there is improvement to better manage this infection after transplantation with CMV prevention that we can discuss after, but still this is, as you can see here, the most frequent infectious opportunistic infection after transplantation, as you can see here, most in the first years after transplantation compared to the other opportunistic infection. And even with what have really improved the incidence and the outcome of this infectious disease with the direct antiviral drugs, the most common use is the valganciclovir and ganciclovir. And so the problem with this disease is that even with the prevention, there is still a percentage of patients in which we have to introduce the antiviral treatment as a curative treatment, with the risk of CMV persistence. That means even with the antiviral drugs, we can't have a negative PCR in the blood, and patient could relapse with 20% of clinical relapse. And among those patients, the most difficult to treat is the one who gets symptomatic with a mutant strain. That is quite rare, but that the most difficult to treat patient. So as I mentioned before, to decrease the incidence of CMV infection after transplantation, we use preventive strategy. So we have either the universal prophylaxis, which is the use of antiviral drug from the beginning of transplantation during either 3 months or 6 months, or the preemptive strategy in which we followed the virus in the blood, and when it's rise threshold, depending of the center, it could be different threshold, we start the antiviral drug as a curative treatment. So those both strategies are efficient for the prevention of CMV-disease. That's why in the last guidelines, you can use either one or the other, but there is drawback there is drawback either with the one or the other. That's why you can use whatever you want, depending of what is the less annoying for you. So in Bordeaux, we use universal prophylaxis because it's more easier to implement. You don't have to follow each week the PCR in the blood of the patient. It prevents other herpes virus that can occur after transplantation, such as HSV or VZV. But the main drawback with this strategy is the drug side effect of the viral vanticlovir, such as neutropenia, which sometimes is very difficult to manage. On the other end, the preemptive strategy is more difficult to implement because you have to get the result of the PCR in the blood of the patient, call back them, and introduce the antiviral drug fastly to avoid the occurrence of CMV disease. It doesn't prevent the other herpes viruses, but there is a less drug toxicity. So what I would like to show you in this presentation is how we can improve both prevention strategy and the management of the difficult to treat disease that as mentioned before. So I would like to present four different aspects of those. So the first one is the use of a novel drug in the prevention strategy, which is Letermovir. And I would also talk about the MTO Inhibitor. That is an immunosuppressive drug that we use as a maintenance immunosuppressive drug after transplantation. And we showed that it has an effect in the decrease of incidence of CMV infection after transplantation. And some words about the improvement of the diagnosis of mutation in patient and the use of maribavir, which is another antiviral drug that could help in the context of difficult to treat disease. So conceptually, there is two different approaches to answer how we can improve CMV management. In one way, as I told you about Letermovir and maribavir, you can have an eye on the drug, the direct drug active against CMV infection. And in the other way, you can also have a look on how you can improve the immune response against the virus and modulate drugs that could help to enhance the effectiveness of immune response, and then lead to a decreased incidence and better control of CMV disease after transplantation. So in the first way, I will talk to you about Letermovir. And so what we have as an interesting result that have not been published yet, but presented in the ID Week, is the use of Letermovir in the universal prophylaxis context in D plus R minus patient. So D plus R minus patients are defined with the serology of CMV at the beginning of the graft, with D plus, it is the serology positive for CMV for the donor, and R minus is the serology negative for CMV in the recipients. And we know that those patients are the most at risk of developing severe CMV disease after transplantation. And as I told you before, the problem with the classical antiviral drug is the side effect with neutropenia that could lead to stop the drug and to have CMV disease after all. And so how we can approve it is using an antiviral drug that have less drug side effects, such as Letermovir. And it has been studied in this randomized trial in the context of D++ patients. So the study design is to compare Letermovir to valganciclovir. So for Letermovir, which is not preventing other herpes virus, the patient have also valaciclovir to prevent HSV and VZV, and it was compared to the classical antiviral drug valganciclovir during 6 months, because it's the classical period in D+ patient for the universal prophylaxis. And then they observe the occurrence of CMV-disease, and it was a non-inferiority study. And they were also pre-specified safety endpoint tested for significance, so the leukopenia and neutropenia. So we can analyze specifically the statistical significance for those parameters. So as you can see here, it was a multicentric international study, and they can include a significant number of patients in each arm, so about 250 in each arm. And so as you can see here, it was a non-inferior analysis. So we observed that there is the same occurrence of CMV disease in the Letermovir arm and in the valganciclovir arm, so about 10 and 11%, which is very low, because in the classical studies, it was more about 16%. So this was the adjudicated evaluation of CMV disease. And so when we have a look on CMV disease declared by the clinician, we see that we are more close than the percentage observed in classical literature, about 70%. And so the most interesting result was about the occurrence of side effects such as leukopenia and neutropenia during prophylaxis. And as you can see here, we see significant lower occurrence of leukopenia in the Letermovir arm. And so I think it could be a very interesting drug in the setting of universal prophylaxis, in particular in D+ patients, because in those patients, we need to put at least 6 months of prophylaxis. So it's a long duration compared to R+, where it's only 3 months. And if we have a drug that have less drug effect, it could be a good option. So it's not yet approved in France. I don't know how it is in the other European countries. So we hope to can use it in 2024. But compared to valganciclovir, it will be much expensive. So we should have a look on that and to target the good patient to use this drug. So the second conceptual aspect for CMV improvement is to also better target immune response and to use a modulate treatment that can enhance its response against CMV. So that's what we observe with MTO inhibitor. In France, Lionel Cousy, who is the head of our unit transplant in Bordeaux, lead this multicentric French randomized trial in which we compared 2 arms of maintenance immunosuppressive treatment based on cyclosporine. And in one arm, we have a patient with everolimus, so MTO inhibitor, and in the second arm, we have a mycophenolic acid. So we use a preemptive strategy, which means we follow the CMV anemia in the blood of patient, and we start a curative treatment after if a threshold of 5,000 units per ml of CMV anemia was observed, and we compare it in the two arms. So we use a composite primary endpoint composed by CMV-D anemia. CMV-D anemia needing the introduction of antiviral drug, graft loss, death, and discontinuation of the study. And as you can see here on the outcome we interested in on CMV, we can see that both on composite primary endpoint and on CMV-D anemia and CMV needed the introduction of antiviral drug. Patient with MTO inhibitor had a significant lower incidence of those parameters. And one also point, an interesting point is that everolimus, unfortunately, is not very well tolerated for some patients. So we have 30% of everolimus discontinuation, which is quite a classical scene in the global literature. But we took advantage of this observation to make a post-hoc analysis comparing the incidence of CMV-D anemia following by antiviral treatment in the patient who continued the treatment during all the study to those who stopped the treatment. And we see that in those with good tolerance, we see a very, very low percentage of patients needed the introduction of an antiviral drug. That means that in patients with everolimus, for whom everolimus is well tolerated, it's a very interesting immunosuppressive maintenance to avoid CMV infection and CMV disease. And the second part of this presentation was focusing on the management of difficult to treat disease. The first problem with this is that we don't really know when we have to screen the occurrence of mutation, because as you can see, the patient we use a lot of antiviral drug for the prevention and for the treatment, and at some point we need to screen if there is a mutation or not. So for the moment, the last previous guidelines define the need to screen for this mutation after 6 weeks of treatment. So either prophylaxis or curative treatment, or when there is no improvement during CMV disease after more than 2 weeks of curative treatment. So as you can see here, there is no clear evidence about why we use this cutoff of 6 weeks, and that include prophylaxis, during which we suppose that there is no CMV replication, and curative treatment. And we were wondering if the occurrence of mutation is more driven by the fact that there is a genetic pressure of the use of antiviral drug when the CMV is replicating. So we tried to test several scenarios, both this classical definition and the duration of treatment when CMV is replicating. And so using the two definition, we use a ROC curve to see which is the one that is the most interesting to predict the occurrence of mutation. So either duration of total cumulative valganciclovir, or the duration of CMV-D anemia under valganciclovir curative treatment. And as you can see here, we have really a better ROC curve using this last definition, with a cutoff of about 8 weeks, with a good sensitivity and specificity. And so when we compare the patient with or without mutation using those two different definitions, so under or higher 6 weeks of total cumulative valganciclovir, or under 8 weeks, we can see that when you have more than 8 weeks of the use of valganciclovir during CMV replication, it's really well predicting the occurrence of CMV mutation. And so to finish about the management of difficult to treat disease, I would like to talk a little bit about maribavir. So this is the study I would like to present, which is very interesting. This is a randomized trial that explore the utility of maribavir for refractory or resistant CMV infection. So in this study, the definition was were those ones. So refractory CMV-disease was was defined by no CMV anemia decrease after 2 weeks of curative treatment, and the resistance was defined as a refractory CMV infection with identified mutation inducing ganciclovir or foscavir resistance. So the study design was as followed. So the patient were after the patient were defined as refractory or resistant, they were included to receive either 8 weeks of maribavir or the investigator assigned therapy for also 8 weeks, so either viganciclovir, foscavir, or cidofovir. Those patients in the last arm could have a rescue treatment by maribavir, and the evaluation was at 12 weeks after treatment. So as you can see here, it was not perfect, but still in the group with maribavir, we have a significant higher level of clearance after 8 weeks of treatment. And we also observe a higher rate of symptomatic free and clearance at 8 weeks, and the maintenance at weeks 16. But as you can observe, the relapse was very frequent, and we can also observe that those results could not be extrapolated to all patients, because at the inclusion in the characteristic description of patient, there were a low number of patients with symptomatic CMV infection and with high level of viremia. So we don't know if we can extrapolate the use of maribavir for those critical patients. And the statistical difference for the endpoint I mentioned was almost true for the patient with identified mutation, so 63 versus 20% of clearance. And it was not significant for patients with refractory definition without the identification of mutation. And to finish, we don't know if the use of maribavir in case of relapse conduces to the occurrence of a mutation for maribavir, and so if it's possible to reuse maribavir in those patients with relapse after first line of treatment by maribavir. I think I finished here, so I hope I was not too long, and I thank you for your attention, and I'm very pleased to discuss with you about the different results.
Thank you very much, Hannah. That was a great update on the topic, on the hot topics of CMV. I have a few questions. In the immune monitoring of the patients who have CMV, do you think there may be an interest of using the ELISpot or the quantiferon CMV, for instance, in patients who develop CMV and who are treated for the CMV?
Yes,
to stop the treatment, or how do you think this can evolve?
Yes, so it's a subject of interest for us, because in HORIS, for example, we will try to define an immune response associated with CMV infection and with the control of CMV infection during those difficult to treat patients. So I didn't present the result because it's quite, so the more convincing one have been published by Oriol Bestard and Oriol Manuel in 2020. So they use the ELISpot only in HR-positive patients at day 15 after transplantation. And what they observe is that in the one with a positive result, it was very well associated with the absence of CMV infection after transplantation. So in the patient with a positive ELISpot, it could be an interesting tool to avoid useless antiviral treatment and useless preemptive strategy also. But the problem with ELISpot is, so the first scenario is so in the first step after transplantation, to know if there is a need of either preemptive strategy or prophylaxis. And this has been well demonstrated by the both oil. The problem with ELISpot is if it's negative, it's not predictive of either CMV control or CMV infection. Probably because it is testing only conventional T cell, and when it is negative, but patient have not CMV infection, perhaps it's other factor, other cellular actor that are involved in CMV control. And so I think and in D plus or minus patient also, we know that ELISpot will be negative. So we'll in those patients with a higher risk, we still don't have any marker for the prediction of CMV infection. So yes, so for R plus patient, I think it's really interesting to know if there is a need of prevention. And what have not been studied very well is the other clinical scenario where it could be interesting, meaning in when you increase immunosuppressive drug, for example, after acute rejection. For example, in Bordeaux, we put 3 months of Valganciclovir to everyone, but if we can have a clue with an immune monitoring, it could be interesting to know for which patient we can avoid this restart of antiviral drug. And after the other clinical scenario in which it could be interesting is during CMV-disease, to know how long we need to keep the antiviral treatment, and when predicting when the patient is going to recover. And also in this scenario, it has not been well characterized. So okay. For now, the more the clinical scenario in which we know that we can use it is in R plus patient at D0 of transplantation to avoid useless prophylaxis.
Okay, and you were talking about patients at risk. So at the beginning of the transplantation, after treatment of rejection, when you switch treatment, we had some experience with the belatacept in Rouen. What do you think? Could you summarize the conditions in which we should be wary of infection? What, in your point of view, which patient should we focus on?
Yes, we discussed recently with Philippe Gâteau and Dominique Bertrand about those data for belatacept. So it was very interesting because recently we make the same analysis in our cohort, and we didn't see any increase of CMV incidence. So we have to work on it. And one clue perhaps is about the dose of steroid associated with the use of belatacept, because we realized that in Bordeaux, when we switch belatacept, we put only 5 milligrams of steroid, and this dose could be higher in other center. And so we would like to test if corticosteroid dose is not one of the most risk factor after switching belatacept. But because in our cohort, we have only 2% of CMV infection incidence, which is very, very low compared to the other already published data. But great. So belatacept, I don't know, but we can also monitor what happened on belatacept with ELISpot and other immune marker, for example. And the other at-risk patients are the D plus or minus patient. And I think also, so after acute rejection, there is no data about how to define the at-risk patient after the treatment of acute rejection. And so I don't know, perhaps also we know that sometimes CMV infection is correlated with other infection. So perhaps in clinical scenario or in which patient made a lot of infection, it could be interesting to measure the global immune response to know if they are also at risk of CMV infection development in this context.
Okay, so I have a last question. Are there some concrete perspectives on the CMV vaccine in our at-risk patients or not for the next year?
So I know there is a phase 2 with Moderna about mRNA vaccine for CMV. The problem is as we can observe in our immunocompromised patient with COVID, is that when you introduce the immunosuppressive drug, we know that there is a high percentage of patients that do not respond to vaccine. So I don't know if mRNA vaccine will be better than the other. And so the idea is to try to vaccinate the patient before transplantation when they are on the waiting list, and perhaps to offer a boost after transplantation when we start the immunosuppressive drug, hoping that the memory response could be better than the naive one when the patient are under immunosuppressive drug. So perhaps this kind of pre-transplant vaccination and then recall after transplantation could be something that could improve the response.
Merci.
So I'm still a junior doctor who still has to work in the ER. So I'll just get back to some basics, if that's okay. So let's just imagine a patient with a kidney transplant comes into the ER and has a fever. When should I suspect CMV?
So so as I think CMV infection is still opportunistic infection that occur in the first or first year of transplantation. So having a look on how long the patient is transplanting for is a very important question to know if CMV infection is a good hypothesis for the fever of the patient. So it's the incidence is higher between 1 to 2 years after transplantation. And as we mentioned before, when there is an increase of the immunosuppressive drugs, so such as after an acute rejection, for example, if we also, I think very interesting to check is if the patient is under prophylaxis or not, because it's still very rare to develop CMV infection or CMV-disease when the patient is under universal prophylaxis. But what we have to check is also the dose of prophylaxis, because sometimes, for example, after transplantation, the patient have a very poor graft function, so we adapt the dose of valganciclovir to this function, and then he recover the graft function, and we forget to adapt the dose of valganciclovir, and this is also a risk for developing CMV infection, the suboptimal dose of valganciclovir. So this is very important to look at. And I will say there is really a close correlation between the immunosuppressive state of the patient and CMV risk, but still we don't have the perfect tool. We can't really test it, but the scenario I just mentioned is one of the most frequent.
Still some very basics.
Yeah.
What kind of diagnostic workup should I do then if I suspect CMV?
No, also the serostatus, of course.
Yeah.
We know that the +- patients are the most at risk. We know also, so if we stay in the kidney field, but also if in general in organ transplantation, we know that the type of organ transplanted is also involved in the risk of CMV infection. For example, lung transplant are at higher risk to develop CMV infection. And so the kind of immunosuppressive drug, for example, in R+ patient, we know that the use of thymoglobulin is also a drug that increase the risk of CMV reactivation after transplantation in R+ patient, because conceptually it's totally depletes the preformed immune response. And so we previously observed that in the +- patient, thymoglobulin did not increase the risk of those patients because there is nothing to deplete as a specific immune response, but only in R+ patient with preformed CMV immunity, the risk is higher with thymoglobulin compared to no induction or bacilliximab.
Could you just say again one more time what kind of symptoms are typical for patients with a CMV infection?
I didn't precise it, but so you can have just the what we call the syndrome. the CMV syndrome, which is like a flu. So just, myalgia with a fever and fatigue, so which is not specific at all. And the most frequent symptoms in a kidney transplant recipient is the colitis and the pneumonia. And less frequently, we can observe retinitis and encephalitis and hepatitis also. We know that it could also affect hemoglobin. It could lead to thrombocytopenia also, to neutropenia. So sometimes it's difficult to know if it's the antiviral drug or the virus that lead to neutropenia. That are the most frequent symptoms.
Merci.
So I have a couple of final questions. The first question is kind of curiosity, looking from Austria and from Germany to France. So question actually to both of you. How many transplant centers do you have in France? And this question comes because there's a lot of discussion here in Germany whether or not we have too many centers. In Germany with, I think, 82 or so million people, we have 42, 43, if I'm correctly informed, transplant centers. How does it work in France? How many centers do you have about?
So I think there is at least, so in France, it's organized by area. So for example, in Bordeaux, we manage all the list of Aquitaine. All the area in the southwest of France,
which is a large region, actually.
Yes, which is
comparable to Bavaria or something like that.
Largest region in France, so that's why we have one of the higher number of patients on waiting list. I think there is at least I don't have it perfectly in mind, but I think there is at least 10 centers in France that manage their own waiting list in
I would say even more. Actually, you have one for every CSU, which is the University Hospital Center. So I don't know the exact
15, 90?
Maybe.
No, 15 or 20 perhaps.
Yeah.
And
because
then also
even
20...
in Paris there is several centers that have their own waiting list also.
Yeah, and this corresponds then also to 20 centers who do transplantation, or are there more centers doing transplantation than centers who do the organizing stuff?
Yes, so only the university hospital manage the recent transplantation, so the inscription on the list, on the waiting list, and the immediate post-transplantation. During the 3 first months, the patients are only followed in the university hospital, but after that, at least, for example, in Bordeaux, we share the follow-up of the patient with the nephrologist who used to follow the patient before transplantation, and so there is alternate consultation between the nephrologist of the patient and us. But I think I know this is not the case for all centers.
But transplantation itself is only done then in Bordeaux, so all people from Aquitaine go to Bordeaux, and all people from Normandy, or at least from Lower Normandy, Upper Normandy, sorry, go to your center, Dominique?
Stimmt.
All right. Then once you stop the prophylaxis, you told us that you do prophylaxis actually in every people who are at risk. How often do you check CMV and the blood afterwards, after stopping the prophylaxis? How often do the people come to your center or to the referring nephrologist for checkups?
Yeah, so this is called the hybrid approach, but it doesn't lead to improve CMV management, because as you mentioned, if we don't screen for CMV frequently after stopping valganciclovir, it still leads to CMV disease, and so it's too late to prevent CMV infection. So we don't used to do that either in the guidelines or in general, because it's not efficient to prevent CMV disease. And after prophylaxis, we used to screen for CMV PCR in the blood of patient only in case of symptomatic patient.
Then switching to treatment, it's fine to see that finally there are some new drugs, because I think for 2 decades or so, nothing new came out, while we see so many novel drugs in hepatitis, in HIV, maybe also in COVID-19, who knows. But there are 2 novel drugs, and thanks a lot for sharing these very novel data. How comes that one drug is tested in prophylaxis and the other one is tested in a refractory disease? So is this kind of strategy of the companies who produce the drugs, or is there an academic idea behind it?
So Letermovir, we learned about Letermovir in the scenario of universal prophylaxis from hematological patients, because for those patients, valganciclovir is a bad drug because of neutropenia. And so they use Letermovir from more than, I don't know, so the published data have been done more than 10 years earlier, and so they use Letermovir for many years. So we learn from them, and so maribavir, it's about a failure of the good dose use in previous data, because they start preliminary trial using maribavir as a prophylaxis drug, but so with several drugs. And when they wanted to test it prospectively, they used the lowest one, and they failed to show a good outcome on CMV prevention. So they just give up this. But I think we can start again with higher dose for prophylaxis. And for refractory drug, it's really a question about pharmacology, because we know that Letermovir has really a low genetic barrier on CMV, and that it's not efficient and could be dangerous to use it when there is a CMV replication, because it will lead to fast occurrence of mutation. So really, Letermovir should not be used alone as a curative treatment because of those characteristics.
And then finally, I would like to briefly discuss your fascinating data on MTO inhibitors. So the first question here would be, do you believe that this lower incidence of CMV disease is just because MTO inhibitors are kind of weaker immunosuppressive drugs than mycophenolate? Or do you believe, and you did a lot of immunological work in this field, do you believe that there are specific effects upon T cells that explain why we see much fewer CMV diseases in these people?
It's a very good question. So I think there is at least 3 reasons for which MTO inhibitor is involved in the lower incidence of CMV infection. Compared to MPA, I think there is nothing to discuss, because MPA is a really efficient drug to decrease T cell proliferation and activation compared to everolimus. And also in the association of immunosuppressive drug, because we know that when combined with MPA, the threshold, the residual level of cyclosporine is higher than when you use it in everolimus, so with everolimus. So that could also be a reason why, when you have the regimen cyclosporine plus everolimus with lower level of cyclosporine, you are less immunosuppressed than with the combination of MPA plus cyclosporine. There is a third argue of the direct effect of MTO inhibitor on CMV replication. We know that in vitro there is a direct effect of mTOR inhibitor on the cycle of the virus. But an argue against that is that the use of everolimus in D+- patient is not leading to a decrease of CMV occurrence. So that is an argue against the first one, and the second one about mTOR inhibitor effect on CMV proliferation. And the third argue is, as you mentioned, the direct effect of mTOR inhibitor on immune cell, and that's what I've done in my PhD. We observe a direct effect on the preformed CMV immunity in vitro, both on the decrease of inhibitory receptor at the cell surface and on the transcriptional program, and also in functional assay. When we put everolimus alone, so independently of other drug, we have an enhance of CMV immune function. So that's an argue to say that there is an intrinsic effect of mTOR inhibitor on the enhancing function of CMV immune cells. So yes, it's not a direct demonstration, but and also the last thing is that we also use in vitro mTOR inhibitor plus cyclosporine on the function of CMV immune cells and on the phenotype. And we see that independently of the cyclosporine and the drug of cyclosporine, we still have this direct effect of mTOR inhibitor on the phenotype and on the function of CMV specific cells.
So my last academic question. Surely your findings are somewhat provocative for transplant physicians, because we had kind of a consensus following the Symphony studies and other studies that the best triple therapy for long-term outcome would be steroids and tacrolimus and MMF. And now you show these data that at least when it comes to CMV disease, that there apparently is quite a large advantage for mTOR inhibitors. At the same time, we learned time and again, and also in your study, all the side effects. There are some cohort studies suggesting even a higher mortality. Also in your study, you had 3 versus 1, if I remember correctly, deaths, more deaths than the people who received mTOR inhibitors. So will you change at your center in Bordeaux your general approach to immunosuppression?
So I have still something to say about the use of mTOR inhibitor. I think it could be a good drug during the first year after transplantation in R+ patient to avoid CMV infection. But we are analyzing, and there is also other team that analyze the long-term effect of the association of mTOR inhibitor with CNI, showing that it could be deleterious for the graft function at 3 or 5 years after transplantation. So perhaps the best way to use it is avoiding CMV infection, using it during the first year after transplantation, and then perhaps switch to a more conventional immunosuppressive regimen, because so in our cohort, we are analyzing the data, and we show that the long-term effects are not as good as those with MPA plus cyclosporine. So perhaps the best way to use it is to use it early after transplantation, and then perhaps switch it for MPA plus CNI.
Thanks so much. So before switching the mic back to Sarah and Dominique, thanks again for this great work. And I would just briefly mention that unfortunately we have to leave Sarah behind here in Bordeaux. She won't be with us for the next 2 weeks because she has to go to night shift work, but we will be supported, Dominique and me, by our colleagues from Austria for the next weeks. The tour will go tomorrow to Limoges. We will meet somebody very interesting who did a lot of academic work at Limoges. So hopefully, Sarah, you will come back for our next Tour de France 24.
Moi, j'ai juste quelques questions concernant Bordeaux. Donc, on s'arrête à Bordeaux, on fait notre petit tour de France. Sébastien Rubin nous avait parlé des cannelés qu'il fallait goûter à tout prix. Est-ce que vous pouvez nous recommander quelque chose à manger à Bordeaux?
Alors pour manger, moi, je suis à fond sucré aussi. Donc, comme Sébastien, je recommanderais les cannelés quand même. Je pense qu'il vaut mieux 2 fois qu'une. Et après, après c'est finalement... je dirais, enfin après, je suis pas originaire vraiment de Bordeaux à la base. Hein. J'y ai atterri après mon internat, comme Sébastien d'ailleurs. Et du coup, il y a toute la culture du vin, donc ça, voilà, c'est pas vraiment à manger, mais plutôt à boire. Et après, à manger, c'est plus la culture du Sud-Ouest en général, mais parce que bon, par exemple, j'en ai parlé avec mon cher et tendre hier, il m'a dit, tu peux leur parler des lamproies à la bordelaise, mais honnêtement, je ne les ai jamais goûtés. Et je ne sais pas si les gens aiment la lamproie, mais c'est une des spécialités bordelaises. Et après, c'est plus la culture du Sud-Ouest en général, mais du coup, c'est moins Bordeaux que voilà, donc tout ce qui est foie gras, canard et compagnie. Vous pourrez en manger à Bordeaux, mais c'est quand même pas là exactement que c'est produit, etc. Et pareil, les pommes de terre à la sarladaise, c'est quand même plus sarlat que Bordeaux. Donc ça, je les ai goûtés et franchement, je les recommande quand même. Donc voilà, à manger, comme je suis moi-même en plus végétarienne et que c'est du coup pas vraiment ma culture culinaire, on va dire, voilà ce que je peux vous en dire. Donc les cannelés, c'est très bien.
Très bien. Donc on part avec le ventre plein maintenant et on peut faire notre sortie culturelle.
Ah, voilà. Alors la petite sortie culturelle, alors dans Bordeaux même, il faut quand même aller se balader sur les quais pour voir la place de la Bourse et le miroir d'eau, là, que vous voyez. On le met toujours dans notre présentation, mais c'est quand même assez sympa. Et donc, c'est tout le vieux quartier bordelais qui est patrimoine UNESCO. Donc, c'est vraiment un petit centre très, très charmant. Donc, se balader devant et puis dans le petit quartier à côté, où vous aurez d'ailleurs des très bons restos tout autour, là. La Cité du Vin, donc vous voyez, plus moderne, qui est au bout des quais, avec cette forme un peu d'urinal qui est magnifique, comme vous pouvez le voir, un petit rappel néphrologique, voilà, et qui est beaucoup plus récente. Et puis, une visite que j'ai beaucoup aimée, que j'y vais assez souvent, c'est qu'en fait, ils ont réhabilité la base sous-marine historique de Bordeaux. Je ne sais pas si vous en avez entendu parler, pour faire... donc, c'est l'ancienne base militaire navale, en fait, pendant la Seconde Guerre mondiale, qui a été conservée à l'identique, mais réhabilitée en musée des Lumières, où en fait il y a des projections d'œuvres de différents artistes. En ce moment, c'est, comme je vous ai mis ici, c'est Salvador Dali et Gaudi, donc très espagnol. Et voilà, en fait, ils font un agencement des œuvres qui se prête particulièrement au fait que du coup, ça se reflète dans l'eau. Et donc voilà, je vous le conseille, c'est une visite assez courte qu'on peut faire avec des bébés, puisque j'y suis allée avec ma fille, ça s'est très bien passé. Voilà, et puis une dernière chose aussi sympa à faire, bon, si on est motorisé, puisque c'est un peu difficile d'accès en transport en commun, c'est les visites des châteaux qui ont la particularité à Bordeaux d'être vraiment à proximité même de Bordeaux. Donc il n'y a pas besoin de faire des kilomètres pour voir des très belles... des très beaux domaines. Et donc là, je vous ai mis par exemple un que j'ai moi-même visité, qui est le château Smith-Au-Lafitte, qui est une petite dégustation aussi éventuellement, et un très beau domaine.
Parfait,
Voilà.
merci beaucoup.
Merci Anna pour cette visite et pour ce propos formidable.
Quand vous voulez, ou sinon l'année prochaine.
So thanks a lot again. Have a nice evening and see you hopefully quite soon
Thank
again.
you again for the invitation and the discussion.